Hello, Low Carb Denver. My name is Will Yancy. I'm the director of the Duke Diet and Fitness Center and an associate professor of medicine at Duke University, and I'm excited to talk to you today about carbohydrate restriction for diabetes, clinical trials, clinical experience, and clinical guidelines. I'm very sorry I can't be with you all today in Denver, but I'm glad that I'm able to record this so that you can view it at some later time, and I appreciate this opportunity that Low Carb Denver has given to us in these times where we're having to do things quite differently. So here are my disclosures. And here's the outline for my talk, which fits with the title perfectly. So I'm first going to talk about a number of clinical trials that have informed us about carbohydrate restriction in the setting of diabetes, some of which have been our own. And then I'd like to spend a little time to introduce you to the Duke Diet and Fitness Center and our clinical experience there with low carbohydrate eating plans. And finally, I'd like to put things in perspective with a clinical guideline that I helped to put together for the American Diabetes Association. So we'll start with the clinical trials. And this trial was not done in patients with diabetes, but it really is what kicked off my career in research, and so I wanted to spend a little time with it. I moved to Duke and Durham after my residency training to learn how to do research, and teamed up with a doctor named Eric Westman, who many of you may have heard of or be familiar with. And he was my mentor during my early career. And this was the second study that we performed on low carbohydrate eating. He had performed a pilot study that I helped out with it partway through, and then we designed this study, which is our first randomized trial of low carbohydrate eating compared to a low fat diet. And it really opened our eyes about the potentials of low carbohydrate eating. And in this particular study, we showed that a low carbohydrate eating plan can lead to greater weight loss than a low fat, low calorie plan, and also some metabolic advantages in regard to changes to blood cholesterol levels, such as HDL and triglycerides. And it helped us to understand a little bit the health benefits of these eating plans, as well as understand some of the side effects that may happen. In fact, this is one of the few studies that documented the side effects that can happen with a low carbohydrate eating pattern. So along the same time that we were performing and reporting that study, we were introduced to a researcher who was looking at low carbohydrate eating for blood sugar control. And this study really opened our eyes to the potentials for reducing carbohydrates to control blood sugar in the setting of diabetes. So this was a very short-term study where patients were put on either a high carb, an intermediate carb, or a low carbohydrate diet for 10 days, and then came in to eat a meal on whichever plan that they were following, and their blood sugar and blood insulin levels were monitored over 3 hours after that meal. And the curves are quite obvious. I think that you can see that with the low carbohydrate diet plan, the glucose level shown here hardly increases, whereas with the intermediate and high carb plans, it does increase and then tapers off, as you would typically see with measuring glycemic levels after a mixed meal. And similarly, the insulin level hardly increased at all with the low carbohydrate meal. However, it spiked with both the intermediate and high carb meals, and then came down over the 3 hours. So this made us think that this way of eating could have high potential for helping improve blood sugar control in people with diabetes. But at the time, the American Diabetes Association and other guidelines did not necessarily recognize this way of controlling blood sugar, and in fact emphasized more treatment with medications and emphasized allowing patients with diabetes to eat a wide variety of foods and covering those foods with insulin or other medications, as can be seen in this statement that says, in individuals receiving intensive insulin therapy, the total amount of carbohydrate in the meal did not influence glycemic response if the pre-meal insulin was adjusted for the carbohydrate content of the meal. In other words, whatever a patient with diabetes ate could be covered with insulin and control the blood sugar. But as later studies showed, there may be some limitations to this. For example, in several studies, weight has increased with more intensive, particularly insulin-type therapy for diabetes. And this is the Accord study that shows quite obviously that with the intensive arm, weight increased over time, whereas with the standard treatment arm, where intensive therapy was not emphasized, weight stayed fairly stable. And another issue that comes along with intensive and particularly insulin-type therapy is hypoglycemia rates. And this is a study called the Advanced Trial that documented the number of events with intensive treatment in the dark teal, and then with the standard treatment with the lighter grayish bars. And you can see that with intensive treatment there were quite a larger number of severe hypoglycemia events in terms of percentage of the patients who were involved in the patients with this intensive treatment. So hypoglycemia is a real concern in these types of trials, and actually these trials, Advanced and Accord, were the ones that showed that intensive treatment did not actually improve or benefit major outcomes like cardiovascular disease, and part of the thought was related to the hypoglycemic events that occurred with intensive therapy. So what do these studies tell us? Well, first of all, that nutritional change, particularly carbohydrate reduction, can have a powerful impact on blood glucose and insulin, and that nutrition has some potential advantages over medications in managing diabetes. So we embarked on a few clinical trials to look at the potential for treating people with diabetes using low-carbohydrate meal plans. So this was our first pilot study done in the VA Medical Center, and we enrolled 21 patients with type 2 diabetes and followed them for 16 weeks on a low-carbohydrate plan. The graph shows very clearly that their hemoglobin A1C improved on average from 7.4 to 6.3%. But more importantly, we saw that we were able to reduce medications in these patients. So blood sugar improvement occurred over 16 weeks, but they were on less medications, which was really contrary to the thought for managing diabetes at the time. So 7 of the 21 patients were able to stop their medicines, 10 of the 21 reduced, and even the 4 that were left over did not change their medicines. So no medicine increases occurred. At the same time, A1C improved. This led us to a randomized trial where we actually compared a low-carbohydrate plan to what we thought would be the most recommended diet going forward, a low glycemic index diet. So we were trying to be proactive and control and use a control that would be considered state of the art at the time, and glycemic index was quite popular and showing some promise for improved blood sugar control in terms of nutritional therapy. So the low glycemic index diet is here on the left side, the low carb diet on the right side, and in the nearly 50, or in the 50 individuals that were enrolled in this study, you can see that A1C improved almost statistically significantly greater with the low carbohydrate plan compared to the low GI plan. But meanwhile, more participants in that arm had medications reduced. So A1C seemed to do better, although marginally of marginal statistical significance, but the diabetes medications were reduced more. And at the same time, weight decreased more. And with the low carbohydrate plan, we did not actually communicate that calories should be reduced, but we did with the low GI plan. And in fact, many other studies have been done on low carbohydrate and many other eating plans in patients with type 2 diabetes. And this interesting network meta-analysis that compares all of the studies with all of the different types of diet approaches actually identified 56 trials that enrolled almost 5,000 participants comparing 9 different diets that are listed here, and found that for reducing hemoglobin A1C, the low-carbohydrate diet was ranked as the best dietary approach, with this area under the curve of 84% compared to the Mediterranean diet and the Paleolithic diet. So it seems that this approach may be most effective for improving glycemia, particularly measured by the A1C, our current standard. So I want to shift now. All of this information that I presented helped us to design our most recent study, and I want to give you some of the details from it. It was called Jumpstarting Shared Medical Appointments for Diabetes with Weight Management, and you can see my co-authors on the paper listed below. This was recently published in late 2019. And if you're not familiar with shared medical appointments, I think many people are using them nowadays. It's a healthcare system redesign involving group meetings of patients with a common chronic condition. Sometimes they're called group medical visits, where meetings provide education, self-management enhancement, and medication management. And in diabetes in particular, they've been shown to improve hemoglobin A1C by about 0.5%, as well as other outcomes like blood pressure and cholesterol. The primary method for improving A1C in these SMAs is via medication intensification. So, in other words, a physician or a pharmacist helps patients to adjust their medicines to get their blood sugar under better control while they're in the shared medical visits or appointments. Unfortunately, this medication intensification, as I mentioned earlier and demonstrated earlier, can lead to weight gain, potential hypoglycemia, and in those studies it attenuated macrovascular benefits of glycemic control that we know occur in epidemiologic studies. So most SMAs, it turns out, have not really effectively addressed weight, even though diet is frequently mentioned in these in content in these appointments. And we know that lifestyle modification, more intensive lifestyle modification with weight loss, can improve glycemic control, reduce diabetes medicines, and this could result in fewer hypoglycemic events. So this piqued our interest as a possibility, and so we designed our study. So our question was, in patients with uncontrolled type 2 diabetes, does the addition of a weight management component to traditional diabetes SMAs achieve comparable, in other words, non-inferior glycemic control while reducing diabetes medications, reducing weight, and reducing hypoglycemic events? And we chose to make this a non-inferiority trial because we knew we would be reducing diabetes medications in the patients who were losing weight and reducing carbohydrate intake. So we thought that that might attenuate the effect on A1C in those patients, but we thought there would be these other benefits that we list below. So this was a randomized 2-arm trial over 48 weeks. We enrolled 263 medical outpatient volunteers who had type 2 diabetes. Their A1C was above goal, so that means their A1C was 8% or higher, or 7.5% or higher if they were under age 55. And then a BMI over 27 because we wanted patients who would be eligible for weight loss. And this was placed in the setting of 2 veterans outpatient clinics in Durham and Greenville, North Carolina. So I want to emphasize this is a trial that was done in an outpatient clinical setting and should be a really good demonstration of how these kinds of real-world clinical designs can occur. So for interventions with the weight management arm, our goal was to assist weight loss and reduce diabetes medicines, and we did this using very low carbohydrate eating plan. And then with the SMA alone arm, the goal was to intensify diabetes medications. And those patients received diabetes self-management and education. And in both arms, there was a study physician who met with each of the patient in the small group individually to discuss their blood glucose log and whatever hypoglycemic events they may have had since the last meeting. And then medications were adjusted using algorithms. And as I mentioned, with the weight management arm, typically we were reducing medications, trying to help them to lose weight and also avoid hypoglycemia, which is necessary with low carbohydrate eating. Whereas in the SMA alone arm, we were intensifying their diabetes medicines to try to control their blood sugar. Again, trying to emphasize medicines that did not lead to weight gain, but we did have our primary goal to control their blood sugar. So our main outcome was the hemoglobin A1C change at 48 weeks. A secondary outcome was the medication effect score, which I'll spend some time explaining, and then hypoglycemic events by questionnaire and weight. So I want to highlight this medication effect score because one of the difficulties with monitoring patients who are on diabetes medicines while they're losing weight or reducing their carbohydrate intake is that they need less medication, and by reducing their medication to prevent hypoglycemia, we actually attenuate the effect that we might see on their hemoglobin A1C. So it's important for us to, I think, document what kind of changes occur with their medications, because it's really part of the outcome of seeing their blood sugar control, because they're needing less medicine. And unfortunately, their patients are on a wide variety of regimens, and it's hard to compare these regimens amongst the patients. And so we devised this medication effect score for medication changes, and basically measures the overall intensity of the diabetes medications by summing the percent max dose of each medication and then using an adjustment factor, basically a factor that explains how much you would expect their A1C to improve with each of the medicines, recognizing that insulin has a higher potency than, for example, the glutamides, or metformin might be more powerful than some of the other medications. So we adjust for those different potencies by this adjustment factor, and then sum all their different medications and the percent of max doses together to come up with one summary score. So our primary outcome was hemoglobin A1C, and this graph shows you the results, the main results, with the weight management low-carb eating group in red and the SMA alone arm in blue. And the hemoglobin A1C, you can see, dipped down more dramatically over the first 16 weeks, which is when the main focus of the weight management intervention occurred, and then visits spaced out after that in both arms, and so you can see there was a little bit of a recidivism with the low carbohydrate arm, but in the end it was still slightly lower, although not statistically significantly lower, but that it did meet the non-inferiority threshold, not surprisingly, since it was lower at the end of the trial. So in other words, these two interventions were comparable for improving A1C by about 1 percentage point in both groups, from about a baseline of 9 down to about 8% at the end of the trial. There seemed to be, or there was a greater effect in the short term, and that might be an area where we can hopefully enhance adherence, or maybe enhance other parts of the intervention to help people to maintain the success that they had at 16 weeks. In terms of the medication effect score, you can see that the medication intensity decreased over the 48 weeks with the low carbohydrate weight management arm, but it increased as we would expect with the medication intensive arm, or this SMA alone arm in blue, and this was statistically significant at the end of 48 weeks. And then weight, not surprisingly, went down in the weight management arm compared to the SMA alone arm over 48 weeks. Probably the most interesting result that we've discovered during the study is that hypoglycemic events were reduced with the weight management arm. And this is what we'd hypothesized, but it was really exciting to see this result, that it reduced by 50% compared to the SMA alone arm. And we suspect this is because their blood sugar is controlled now more by nutrition as opposed to medications, and it's the medications that lead to the hypoglycemic events. And in that arm, obviously those participants enjoyed that benefit. All right, I'd like to shift gears now and talk a little bit about our clinical experience with this eating plan at the Duke Diet and Fitness Center. This is a unique place. It's what we call an immersive program, or some people call it a residential style program, where patients come from all over the U.S. and the world and stay for at least 1 week. But we have a 4-week program, and they will occasionally stay longer when they feel like they want to have that longer term benefit that they can receive from our program. And each patient receives an individualized assessment and counseling by experts in medicine, nutrition, fitness, and behavioral health. We have the capability to do body composition analysis, resting metabolic rate measurement, and clinical lab monitoring. And our patients receive 3 meals daily while they are here, and exercise in classes and individually, and we can do some specialized exercises as you can see listed there. And they attend lectures, and those lectures are focused on trying to help them to improve their lifestyle behaviors, as well as understand the improvements that can happen with lifestyle change and the health processes that they are affected by, how they can control those health processes better. The clients, when they're here, have an individualized diet plan and actually devise their own menu. We have a flexible amount of food choices and plans, and the patients, as I said, devise their own menu, so they gain meal planning skills using custom software that we have developed that actually provides nutritional feedback to them after they've devised their plan. We have 3 main diet approaches. The first is a moderate carb, low calorie plan, and by low calorie I mean typically 1,000 to 1,800 calories, lower calorie levels obviously for women and the higher ones for men. We have a low carbohydrate plan, which is approximately 15 to 25% of calories from carbohydrates per day, and then a ketogenic plan, which is less than 15% of their calories per day from carbohydrates. The emphasis with the ketogenic plan is not necessarily calories, but because of our software, we're able to monitor people's calories on a daily basis, and so that's why we do talk about calories with our plans. So I want to show you a few examples of what can happen at our center, and as I mentioned, it's a residential style center, so we can monitor people on a weekly or even daily basis and adjust their medications. And so I think it's a really good example of what can happen with low carbohydrate eating, because we can monitor people more frequently and document what happens with them in terms of their blood sugar, their weight, and their blood cholesterol levels. So our first example is patient SB, who's a 67-year-old male with diabetes, high cholesterol, and hypertension, who really benefited greatly from our program. He was here for 4 weeks. And at baseline, he had a weight of 252 pounds. His blood sugar was out of control, 190 to 300 range, and his triglycerides were high. His HDL was low. His LDL was controlled with a cholesterol medicine, and his A1C clearly was above goal. Over the span of 4 weeks, he was able to really wean off several medications. We have a lot of patients whose blood pressure plummets while they're in our program, so we reduce their blood pressure medicines, and in the first week we had to discontinue atenolol and chlorthalidone for him because his blood pressure had gone so low. We obviously were reducing his insulin at the same time. We do that right off the bat when they start the program, so in week 1 he was already down to about half the amount of insulin, and by week 2 he was off of his insulin and was in addition discontinuing another blood pressure medicine, losartan. By week 3 he had discontinued sitagliptin, and by the end of the program we continued metformin. We actually decreased his atorvastatin because his LDL had decreased even further, and you can see his numbers are much improved. He'd lost over 20 pounds, his blood sugars were in the normal range, his triglycerides were now very substantially normal, his HDL had improved, his A1C had gone down 2% in just the span of 4 weeks. In another patient who actually has type 1 diabetes and many of the other similar health problems, who also had been underwent gastric bypass with some initial success, but then recidivism, joined our program at a weight of 493 pounds. This was a taller man, but still obviously a very high BMI. He had blood sugar that was out of control at the time. His other numbers actually were fairly in control, including his A1C, but he had major improvements in our program over a long span of time because he had a lot of progress that he wanted to make in our program. So he was able to discontinue some of his blood pressure medicine. He actually discontinued CPAP during our program and decreased his pain medication as his neuropathy improved. His anemia that was present at baseline and unexplained actually resolved with improved nutrition and health, and his swelling, his edema, improved markedly. And you can see his numbers by the end of the end of the program. He had actually lost over 100 pounds. His blood sugars were much improved, but more what you'd expect with a patient with type 1 diabetes. His HDL actually did go down. His LDL went up because he had decreased his cholesterol medicine. And his A1C improved by just a couple of points, of tenths of points. But you can see he's on much less insulin and was enjoying much less hypoglycemia. And finally, I want to show the picture of a patient who came to our program over several years. And it first started with a moderate carb plan and then switched to a very low carb keto type plan over the remaining years, starting in 2013. Her weight obviously improved with the moderate carb, low calorie plan, but decreased quite substantially more with the keto plan by 30 pounds and continued to improve over the years. She weaned off several medicines for blood pressure as well as for diabetes and cholesterol, and her numbers improved dramatically. Her A1C, which was under reasonable control to begin with, improved with the moderate carb plan, but then became normal with the low carb plan to the point that it was in the normal range without any medication, and so her diabetes was essentially cured. Her fatty liver disease was also cured over this time period. Her triglycerides came to normal, and even an inflammatory marker, CRP level, improved markedly while she was doing these plans. So impressive results over a long time span, showing that lifestyle can have a big effect and a long-term effect in people if they maintain their adherence to it. All right, finally, I'd like to shift gears to the clinical guidelines that I helped with for the American Diabetes Association. And I want to start by pointing out that these are the only two clinical guidelines that I'm aware of that support a low-carbohydrate eating plan other than some of the low-carbohydrate guidelines that you may have seen out there. So the American Diabetes Association, Nutrition Therapy for Adults, Consensus Report, and the Obesity Algorithm that's put out by the Obesity Medicine Association. And I'm going to focus on the former one since I was involved in that guideline. Well, to start talking about guidelines, I want to talk a little bit about history. Dr. Joslin is obviously famous for his treatment of diabetes and was one of the first to describe dietetic treatment for diabetes and one of the first to give recommendations on how carbohydrates should be restricted, as detailed in this quote. But when insulin was discovered and used clinically, this really changed the way our nutritional approach to diabetes was presented. So this graph, I think, shows you how our nutritional guidelines have evolved over the decades in the 1900s. So the Joslin diet was only 2 grams of carbohydrates, and then over the span of several decades, carbohydrate intake increased very markedly, whereas fat intake decreased fairly markedly. And this is related to the concerns about fat intake and heart disease in people with diabetes, and also the ability to control blood sugar better with insulin while eating carbohydrates. So the guidelines changed quite a bit until the 1990s, when we started recognizing some of the potential hazards of this, and we also recognized there are many approaches that were actually effective, and so things started to vary. But still some emphasis on reducing saturated fat. And then let's fast forward to our most recent consensus report that was published in the fall of 2019, the spring of 2019. There really are 2 overarching messages that I want to communicate from this consensus statement. First, a variety of eating patterns have been shown to be acceptable in clinical trials, but all of these emphasize a few things. First of all, non-starchy vegetables should be emphasized instead of the starchy vegetables. We also emphasize minimizing added sugars and refined grains, and then choosing whole grains over highly processed foods to the extent possible. And then this guideline, I think, was really unique in that it emphasized weight management as having great potential for preventing diabetes and improving diabetes outcomes. So this involves eating plans with energy deficit, whether it's explicitly stated or not, enhancing physical activity, and even using medications or surgery in those cases where necessary. What was new in the consensus statement is that reducing overall carbohydrate intake seemed to have the most evidence for improving glycemia, and this has not been emphasized in prior guidance statements. And this can be applied actually in a variety of eating patterns. So some of the studies were actually Mediterranean diets that reduced carbohydrate intakes. So I think it's important for us to recognize that reducing carbohydrate in several different eating patterns can be effective. And then we also recognize that low and very low carbohydrate eating plans are viable approaches, particularly for adults with diabetes who are not meeting their glycemic targets or who wish to reduce their anti-glycemic medications. So a few recommendations or caveats are really important when you're, prescribing these types of diets to patients with type 1 or type 2 diabetes. Because of the concern for hypoglycemia, it's really important to be in close contact with the patient. And we use appointments every 1 to 4 weeks initially and space those out if things are stabler over time. And it's important for the patient to be able to contact the clinician outside of visits so that they can get advice if necessary. The blood glucose monitoring is really imperative to prevent hypoglycemias, and CGM, continuous glucose monitoring, is especially helpful, and I'm very thankful that that is more available nowadays. In terms of adjusting medicines, it's important to adjust or reduce the doses of insulin and oral hypoglycemic medications right at the beginning of starting the diet. And we typically reduce them by half if the A1C is near goal. We also stop SGLT2 inhibitors because of the increased risk for euglycemic ketoacidosis. And then blood pressure medicines often need to be adjusted, so we're very vigilant about asking about orthostatic symptoms and warning patients that medicine should be adjusted preemptively rather than waiting for symptoms. And finally, I'm sure many of you all are familiar with the keto flu or some of the symptoms that can happen early on when starting a very low carbohydrate plan. And this is because, we think, because of water loss, particularly water and sodium loss that occurs early on in the diet. So as we use up glycogen stores and also reduce insulin levels, our bodies release water and our kidneys release water and sodium as a result of reduced insulin levels. And this can cause dehydration in some of these symptoms. So hydration is really important. We emphasize half the patient's weight in ounces of fluid per day. So that's a much loftier goal than what we've typically taught in the past when we talked about 8 glasses of water per day. And we also replenish sodium, particularly at initiation, with broth being a very efficient source. Now, obviously, in people with congestive heart failure or swelling, you need to be careful with this, but it can really prevent the symptoms if used appropriately. Constipation is common and easily treated with some of the suggestions I've listed here. And then I do want to caution that we don't have a lot of evidence in patients with chronic kidney disease who are pregnant or with disordered eating with these plans, so they should be monitored very carefully. So in summary for this presentation, I think it's been shown pretty clearly that reducing carb intake can lead to better glycemic control, and this allows, in fact it requires, reduction in diabetes medicine. But that in turn can increase weight loss and it can reduce hypoglycemic episodes. So there are many benefits to being able to reduce particularly insulin in patients on insulin. Because of the early diuresis, it's important to ensure adequate intake of fluid and salt, and then recognize that blood pressure and triglycerides decrease and HDL increase, that LDL does not typically increase on this diet as some people are concerned, but it can in some people, so these parameters should be monitored. And then as much as there's a lot of excitement about using these diets in patients with diabetes, and there are certainly important short-term outcomes that we have seen and I demonstrate in this talk, we should also recognize that there aren't any long-term studies that have examined whether the diet approach lowers heart outcomes like heart attacks or actual complications to diabetes or even mortality. And so those studies would be really important to establish this as a primary treatment approach. So with that, I'd like to say thank you. I appreciate this opportunity again to record this presentation. And I'm sorry I'm not there to answer any questions that you might have, but I can be reached outside of the presentation by email, and I hope everybody has an excellent conference.